My name is Violeta Nieves. I'm a UTMB dietetic intern. I'm going to give a case study presentation on reactive hypoglycemia after bariatric surgery. The overview of this presentation is to present the background information on bariatric surgery, benefits, and side effects. I'm going to give the incidence of reactive hypoglycemia in bariatric patients, going to present the patient profile, medical nutrition therapy for reactive hypoglycemia, summarize, and conclude on the case study. So, a little bit of background on my patient. She had laparoscopic gastric bypass surgery in July 2010. She met with a dietitian 19 months after her surgery. This is when she presented symptoms of reactive hypoglycemia. Her medical diagnosis of hypoglycemia was January 2015. So there's four main types of bariatric surgeries done here at the Center for Obesity and Metabolic Surgery, and the patient receives the Roux-en-Y. So the absorptions of nutrients, the intestinal operations, presumably the shortcuts the circuit of the intestine to reduce the amount of calories that are absorbed by the small intestine. And so I want to present a little bit on insulin. Insulin is a peptide hormone that's made by the pancreas, known as the beta cells. And so this allows the body to use glucose from the carbohydrate containing foods for energy and storage. So after eating, blood sugar levels should increase, and the cells in the pancreas, the beta cells, release insulin. Insulin signals the cells to absorb sugar from the bloodstream. This is described as a key which unlocks the cells to allow sugar to enter the cell and be used as energy or for storage. There's many benefits for bariatric surgery. One of those is that it can help resolve comorbidities. This can include metabolic improvements such as glucose control. It also has a long-term control mechanism for the patient to be less hungry, therefore maintaining weight loss. There's also been a retrospective cohort study published in the New England Journal of Medicine by Adams et al., and it looked at approximately 10,000 patients that had undergone gastric bypass. And it looked at probably 9,628 patients that were severely obese as a control group. And so they looked at the results that long-term mortality from any cause in the surgery group was with many benefits of bariatric surgery, there's also side effects. And so I'm going to present two common side effects. One is more common and the other one is less common. So the first one's early dumping syndrome. It occurs 30 to 60 minutes after indigestion of simple sugars. This is due to the rapid emptying of clumping syndrome is also known as reactive hypoglycemia. Hypoglycemia after eating is when blood glucose levels become dangerously low following a meal. It's recurrent and it can occur within 4 hours after eating, occurs several months to years after surgery, and can occur both in patients with and without diabetes. It occurs more in females than males, and clinically significant hypoglycemia occurs in approximately. So why is this important to talk about? The symptoms are severe, or the patient can be unresponsive to dietary modifications. And so I'm going to explain the incidence of reactive hypoglycemia in bariatric patients. It was first described by Service and al. This was a New England Journal of Medicine article in 2005, and it looked at just gastric bypass patients. And so there were 6 patients. They were referred for evaluation of repeated episodes for postprandial hypoglycemia. They could not be controlled, their symptoms could not be controlled by nutrition modification, and so they waited for a spontaneous episode to occur, and they had blood samples drawn for several laboratories. So I'm going to explain the proposed etiologies. Unfortunately, prevalence in etiology has not yet been determined. And so there's proposed etiologies in alteration in beta cells, non-beta cell mechanisms, and then also a combination of mechanisms. And so for the alterations in beta cells, Service et al. Had claimed nocidioblastosis, which is the excessive function of the pancreatic cells, finding of enlarged islets. So this is hypertrophic beta cells, and which can increase insulin sensitivity. And so another proposed etiology is hyperfunctioning of the beta cells. So they looked at the hormone glucagon-like peptide 1, which has been shown to be increased by a greater than tenfold after gastric bypass. And so this hormone, glucagon-like peptide 1, contributes to beta cell proliferation, which is the increase in number in rodent animals. So potentially an increase in insulin secretion, causing a reactive hypoglycemia, which could cause reactive hypoglycemia. For the non-beta cell mechanisms, there has been proposed a decreased levels of appetite stimulating and insulin counter-regulatory gastrointestinal hormone, ghrelin, which is the hunger hormone. Ghrelin cells are found the normal blood glucose levels I'm going to present are based by the American Diabetes Association. So before a meal or pre-prandial, they should be approximately 70 to 130. And so for a patient to be diagnosed with reactive hypoglycemia, this is based on the Whipple's triad. So the first three were created for hypoglycemia, and so the rest of the characteristics are based on reactive hypoglycemia. And so a diagnosis of hypoglycemia is not just based on the symptoms, rather than so endocrinologists like to look at more specific numbers. And so a patient should have a low blood glucose levels less than 50 milligrams per deciliter with a precise method. So this would be more of a plasma with plasma rather than a glucometer. Symptoms of hypoglycemia at the time of a low blood glucose to present the three classifications of hypoglycemia: mild, moderate, and severe. So for mild hypoglycemia, this is a blood glucose lower than 72 milligrams per deciliter. And so the symptoms include shaking, fast heartbeat, sweating, hunger, numbness or tingling around the mouth, and headache or stomach ache. For moderate hypoglycemia, this is a blood glucose down to 45 to 70 milligrams per deciliter. And so the symptoms include anxiety, nausea, headache, impaired vision, personality change. Severe hypoglycemia is a blood glucose less than 73 milligrams per deciliter. And so the symptoms include dizziness, irritability, drowsiness, fatigue, not unconscious, or even seizures. So the patient's profile: she's a 61-year-old Caucasian female. She's single. She has one child. She's disabled, so she doesn't work, and she has no known food allergies. And I want to mention that she's a current everyday smoker. So she smoked a third of a pack for about 10 years. So before her surgery, until 2009, she quit before her surgery, and then she started to smoke shortly after she had her surgery. This is her anthropometric assessment. She's 5 foot 5 inches. Her pre-surgery weight was 259 pounds. So this was a week before her surgery, and her BMI was 43.1. Her ideal body weight based on a BMI of 24.9 is 150 pounds. So her excess body weight is 109 pounds. Her post-operative weight is, so this is the weight from her last clinic visit at the Center for Obesity and Metabolic Surgeries was 176 pounds. And so her percent excess body weight loss is 76%. So she is a successful bariatric patient in terms of weight loss. So this is her weight history, and so this is her graph. And so her pre-surgery weight was 259, as I mentioned earlier, and her last clinic visit, she was 176 pounds. And so this is her past medical history, and this is a timeline. And so in 2008, she became a new patient to UTMB, and so she had a past medical history of hepatitis C virus but about 3 years ago before she became the patient here at UTMB. She had hypertension, hiatal hernia, and GERD. In 2009, she was diagnosed with hypothyroidism, and this is her past surgical history. She had back surgery in the 1980s several times. She had an umbilical herniorrhapathy, and her gastric bypass surgery was in July 2010. And I just want to mention that the rest of her surgeries were related to pain. So the radiofrequency thermocoagulation utilizes radio waves that destroy nerves to help reduce the pain that she had. And so this is her family medical and health history. Her grandmother had heart attack, and her mother and her grandmother had hypothyroidism. So she also received this diagnosis later on herself. So this is the patient's emergency room timeline, and so I included some of the important things of when she became a patient here. And so in 2010, as I mentioned earlier, it was her gastric bypass surgery, and so those are her emergency room timeline are in red, so you could see that she had 4 hospitalizations shortly after her surgery. And so I'm going to explain each of them and more of a descriptive in the next slide. So in 2000, so this was in November of 2010, a couple months after her surgery. She had a chief complaint of dizziness secondary to dehydration. And so this is a timeline after her gastric bypass as she came to speak with one of the physicians here at the Center for Obesity and Metabolic Syndrome. And so I kind of So this is the timeline after gastric bypass with a registered dietitian. So I want to mention that this patient, she was very uncompliant. She was never exercising. She wasn't meeting protein needs. She skipped meals, and her breakfast routine included oatmeal and fruit. And so these, the episodes I'm going to present is after her surgery. So in bold, I put the length of time after her surgery. And so for 7/26/2010, this was shortly after her surgery. She was on a clear liquid diet, so this stage is more for hydration. And so she wasn't doing too much physical activity, and she wasn't meeting protein needs just because she was on a clear liquid diet. And so in 2010, so this was a month after her surgery, she was on a puree diet. She wasn't meeting her protein requirements with a protein shake, and she was drinking less than 64 fluid ounces of water. And 3 months after her surgery, she was on a regular diet. So these are images of her marginal ulcer, and as I mentioned earlier, it's a long-term complication that can happen at the gastrogenostomy. And so it's an anastomosis, so this is a surgical connection between the stomach and the proximal loop of the jejunum. So I'm going to explain the development of ulcers disease after Roux-en-Y incidence, risk factors, and patient presentation and systematic review that's published in the Obesity Surgery Journal. And so it was 41 studies, a total of approximately 17,000 patients, and the results were that 4.6% developed marginal ulcers, and the time between surgery and a marginal ulcer varied between 1 month and 6 months. And some of the risk factors is the use of NSAIDs and abuse on tobacco. And so our patient denied the use of NSAIDs, but she did present with abuse on tobacco. So this is her biochemistry assessment. I want to mention that her lowest glucose level was 77 milligrams per deciliter on April of 2012. And so she was vitamin D deficient most of the time that she was a patient. The reference for vitamin D is 30 to 80 nanograms per milliliter, and so she was deficient. She was also deficient in vitamin B12. The reference value for vitamin B12 is 240 to 930 picograms per milliliter. And so she was vitamin deficient after her surgery. So this is her vitamin D status. So she was deficient before her surgery, as I mentioned. And so with her medical treatment, she had adequate. So the prevalence of deficiency is anywhere between 50 to 80% after gastric bypass and biliopancreatic diversion. The deficiency syndrome is osteomalacia and osteoporosis. The risk factors is that she did receive a malabsorptive procedure. Also, other factors include age, limited UV exposure, and supplement non-adherence. And so some of the symptoms include bone pain. Good food sources are synthesized by the skin or fortified in milk. And then the treatment includes And so for vitamin B12 status, she had adequate values before her surgery, and shortly after, approximately a year, she became deficient. And so the prevalence of vitamin B12 was noted to be 11% 1 year after bariatric surgery in a study that I read. So she correlated well with this study, with these studies' results. And so vitamin B12 is also known as cobalamin, and so the prevalence of deficiency is anywhere from 9 to 14% after gastric bypass. And so this deficiency syndrome include megaloblastic anemia, the degeneration of peripheral nerves. Some risk factors is supplement non-adherence. So in this case, the patient is more likely deficient due to supplement non-adherence. These include some of the symptoms, and so she presented with some of the symptoms such as fatigue, shortness of breath, palpitations, numbness in the extremities. So these were her outpatient medications. I want to mention that the first four were related to her anti-ulcer or her marginal ulcer. And so I want to mention that the first two may decrease the absorption of iron and vitamin B12. So it's important to be aware of that since she already has a vitamin B12 deficiency. And so she's taking some smoking and cessation aid, which have side effects of increased appetite, increased weight. She's taking anti-diabetic, antipsychotic drugs, thyroid hormones, lancets and blood glucose strips to check her blood glucose. And so these are her vitamin and mineral medications. And so it's treating her vitamin B12 and her vitamin D. So her nutritional needs are approximately 1,000 calories. The reason that patients after bariatric surgery need fewer calories is to maintain weight loss. And so there's no specific evidence-based paper that has published the guidelines, but it can be anywhere from, for weight loss, it's anywhere from 800 to 1,200 calories. But based on the patient not doing a lot of physical activity, she needs approximately 1,000. Nutrition diagnosis, I came up with two, just because she wasn't meeting protein needs and she also had vitamin deficiencies. And so for the first one, she had inadequate protein intake related to difficulty of tolerating protein-rich foods, as evidenced by protein intake below 60 to 80 grams of protein. For the second nutrition diagnosis, it's inadequate vitamin B12 and vitamin B12 and vitamin D supplement intake related to nutrition-related knowledge deficit, as evidenced by supplement intake below recommended guidelines and laboratory values of vitamin B12 and vitamin D. For her nutrition prescription, I want to mention that based on research, most patients respond to nutrition modification. And so for her, it's important to reinforce bariatric surgery guidelines, including hydration, nutrition supplements, behavior modifications, and educate her on a 1,000 calorie diet, which includes 75 grams of protein, 75 grams of carbs, and 35 grams of. For her nutrition intervention, it's important to focus on a couple, just because more likely she's going to be willing to follow a couple recommendations rather than all these. So it's important to educate the patient on what are high carbohydrate food items, educate her on the importance of protein and protein sources, and also to recommend her to eat 3 meals and 1 to 2 snacks daily, and separating those 2 to 3 hours apart, and eating protein at each meal and snack. Educate her on appropriate snack ideas for treating a low blood glucose, taking all her vitamins and mineral supplements as recommended, and also to keep a daily food log record when hypoglycemia symptoms are present, and reinforce a regular exercise regimen, and then also recommend the patient to come into the Center for Obesity and Metabolic Surgery continuously for appointments. The goals of the nutrition intervention is that the patients should consume 75 grams from protein, 75 grams of carbohydrates, and 35 grams of fat daily, and space those meals and snacks 2 to 3 hours apart, and then also for her to come at least 2 times a year and have her labs checked yearly. And so these are some snack ideas for treating a low blood glucose: crackers and cheese, pita and hummus, nuts and yogurt, and whole wheat bread and peanut butter. So for her monitoring and evaluation plan, it's important to monitor her weight changes, weight loss since her surgery, weight changes from previous visit, and the percent excess weight loss. Look at food and nutrition related history. So this is fluid status, protein, carb intake, calorie intake, and also her exercise tolerance. Monitor for the use of vitamin and mineral supplementation and encourage compliance. Monitor bone mineral density if available, and then also her biochemical data and electrolytes and blood pressure. Assess compliance with the goals from the intervention. And so here I'm going to mention a little bit of the non-nutrition management of reactive hypoglycemia. And so for pharmacological management, based on research, 3 to 5% might need pharmacotherapy. And so there's 3 drugs that are known to help with reactive hypoglycemia or hypoglycemia itself. So the first is acarbose. So this delays the gastrointestinal digestion of carbs. The second one, it slows the gastric emptying and reduces insulin release. And so the third one, dioxide, it inhibits the insulin release as well. So surgical management, there might be some surgical interventions. So this includes gastric tube placement for enteral feedings, reversal of the gastric bypass, and even pancreatic resection, as I mentioned earlier with the study. And so I just want to mention that the reversal of the gastric bypass sometimes isn't effective based on research. So it's unfortunate that there isn't an intervention that's well known to solve this symptom. And so to summarize and conclude my presentation, I want to mention that reactive hypoglycemia is a descriptor of the timing of hypoglycemia, but it's not a diagnosis by itself. It's important to have continuous glucose monitoring and use it as a useful management tool. And then as my patient, she wasn't following any of the nutrition intervention, so we're unable to detect if the patient is responsive to these nutrition modifications. And regardless of the mechanisms, manifestations are severe. And so it's important to have commitment to long-term follow-up visits as a bariatric patient. And also, it's very important to have lifelong monitoring for micronutrient deficiencies. And so this concludes my case study presentation, and I'm going to present my references in the next slide. So these are my references. Thank you for listening to my presentation.